Does not appear to be advancing. Can we have some help from the back to advance the slide, please? These are my disclosures. There we go. So when we talk about metabolic surgery, I think we're talking about more than operations that cause weight loss and even more than operations that cause improvement in blood sugar. We're also encompassing these other conditions that include dyslipidemia as well as hypertension. So when we look at outcomes, blood sugar, blood pressure, and lipid control should also be included as primary targets for outcomes. And it just so happens that, and these are guidelines by the American Diabetes Association and many other diabetes-focused scientific organizations endorse the same strategy of the sort of triple target, focusing on glycemic control with the aim of acquiring a hemoglobin A1C of 7 or less, even though 7 is actually above normal. 6.0 or less is considered normal. Aiming for normal blood pressure and also normal lipids, including LDL cholesterol, triglycerides, and HDL. And these are the key operations that we are focusing on. Dr. Torcati just described the restrictive procedures, gastric banding, and sleeve gastrectomy. We all recognize that they may indeed have different mechanisms, and so too the foregut and distal bypass type procedures may have different mechanisms as well. And I will focus on gastric bypass and the BPD type procedures as well as duodenal switch. And most of the data that we have, as all of you well know, are primarily in patients with morbid obesity, BMI of 35 or greater. And most of these patients do have metabolic disease, and I'll focus primarily on those individuals with type 2 diabetes. Now, I'm showing you some of the key initial studies. These are retrospective case series data. There's a lot of variability from study to study in terms of definitions of diabetes resolution and definitions of the severity of diabetes. But in general, from these studies, we see that there is significant excess body weight loss in the range of 50 to 60% excess body weight loss, anywhere from 1 year follow-up all the way up to 4 or 5 years of follow-up. And we do see significant reductions in hemoglobin A1C that amount to a fairly significant rate of clinical response or diabetes remission in the range of 60 as high as 89% in the PORI series. Now, when you interpret this data, you have to also look at, again, the population, because the type of patient is an important factor in determining the outcomes. The duration of diabetes before intervention, the severity of the diabetes, the patient's body mass index, all these are important factors that will contribute to the rate of remission. Now, with the biliopancreatic diversion type procedures, we don't have as much data. And also the quality of this data is not at the same level. It's the same in terms of retrospective analyses, but these studies don't, to a large extent, have the same degree of biochemical evidence of remission or improvement. They're primarily based on clinical remission that is defined more variably. Usually it's defined as the cessation or reduction of medication usage as opposed to A1C or fasting blood sugar. There are just not as many studies, but the data that we do have suggests these operations are equally powerful, if not even more effective than the foregut bypass procedures, with remission rates as high as 98% or 100% in some of these series. But I just caution you in interpreting these as procedures that cure diabetes in 100% of patients. Some of these studies show, because we don't seem to have the same degree of quality of data in those BPD type studies. Now, in terms of prospective match control studies, there also are not a large number, but the SOS is, I think, the most important because it has such an incredibly good follow-up that is now approaching 20 years. It has a good control group. While not randomized, the group was matched very well with the bariatric procedures that included banding type procedures as well as gastric bypass. Unfortunately, there were a fairly small number of gastric bypass patients in this series, so the power to compare the different procedures is somewhat limited because of the small numbers. In fact, there were only 34 gastric bypass patients available for follow-up at 10 years. But nevertheless, I think this chart is very informative when you look at the 10-year data comparing these important outcome variables, including weight, body mass index, blood pressure, and so forth. Look at the bottom here is blood glucose and insulin. And you see compared to the control group at 10 years, you see a very dramatic effect for the surgical group overall. In fact, a reduction in fasting blood sugar and a significant reduction in baseline insulin. And when you compare the three different types of procedures, it appears that the bypass procedure has a much greater effect on blood sugar and insulin. This is important because, again, this is a 10-year effect, very durable effect overall. In terms of randomized prospective studies, it's very limited as well. And the most important study here is the Dixon OBrien study that focuses on gastric banding patients compared to a medical treated group of patients that have type 2 diabetes. Now keep in mind, again, the population of patients in these studies is important. These are patients that generally have early diabetes, less than 2 years. The average A1C was 7.7. So these are diabetics that are, fairly, reasonably controlled and certainly not out of control. And none of those patients, none of them had insulin. 60 patients in each group, total 30 in each group. BMI was limited to 30 and 40. And basically you see the major endpoint was remission rate. And remission here was very well defined as cessation of anti-diabetic medication and return to normal A1C, 6.0 or less. In the medical group, only 13%. And the reason why those reached that level was mainly diet and exercise, because anybody who was on medication would be disqualified for remission. The surgical group had 73% remission, and it appeared that most of that benefit was driven by weight loss. The surgical group had 20% initial body weight loss compared to the medical group that had only 1.7%. So very, very important study, and today really one of the only, if not the only, randomized study looking at surgery as a treatment specific to type 2 diabetes. Now, a number of meta-analysis studies have been published over the years. This is the most recent study published in American Journal of Medicine just last year, and all these meta-analysis type studies tend to show the same thing. But keep in mind that this is a collection primarily of retrospective studies that have a variety of varying methodologies and how they evaluated their patients. But nevertheless, collectively, it does appear that the bypass procedures in general not only cause more weight loss, but are more effective at achieving an overall remission of type 2 diabetes. Several studies, including one that I was involved with a few years ago, evaluated predictors. Since we know that not all patients achieve remission, what are the factors that seem to suggest remission versus just improvement over the baseline? And it appears that the condition prior to surgery, the severity of diabetes prior to surgery, the duration of diabetes prior to surgery, the amount of weight loss, all of these are factors that appear to predict the rate of remission post-surgery. That certainly makes sense. What about the other endpoints? Again, it's not just about sugar. There's several studies. This is one that I was involved with a few years ago. This is a very high-risk population with the average BMI of 56 in this series. And we looked at blood pressure, lipids, as well as glycemic control. And we found, at 1 year, very significant improvements in both systolic, diastolic blood pressure, fasting blood sugar, A1C, as well as cholesterol, triglycerides. and improvement in HDL. It's very difficult to improve HDL, the so-called good cholesterol, even with pharmacotherapy. A number of studies have also shown very similar patterns. This was published in the American Journal of Cardiology. Again, showing that most of these are bypass procedures, but even restrictive operations can have very significant impact on endpoints other than glycemic control. Now, we don't know as much about patients with BMI less than 35, which is a very controversial area, but area that's getting a lot of interest. Are the operations as safe and effective for patients with lower BMI? And this is just a short list of what has been published so far. There's about 4 papers with gastric banding. 2 of them are from the same group in Australia. A handful of gastric bypass papers, and a small paper amounting to about 8 patients with BPD. All of these suggest the very similar effects that we see in the morbidly obese population. Now, this is an important study that is brand new. It's unpublished. It was just presented last week at the American Surgical by Eric De Maria. And this is data coming from the BOLD database, the SRC database. And they looked at patients in this database, which now has over 65,000 patient entries. They looked at patients that had a BMI less than 35 with type 2 diabetes. And they found 235 patients. And interestingly, there was an equal number of bands and bypasses, 109 bands and 109 gastric bypasses, and then the rest were a potpourri of other procedures. As you might imagine, the majority were female. The average age was 52, and the average BMI was 33. The lowest BMI was 30. They defined remission by clinical means only because they didn't have biochemical endpoints to evaluate the patients in this database. So cessation of medications was the definition for clinical remission. And what they found was that the 90-day mortality was 0 for all the surgical patients. The morbidity, not too surprising, was much less for the band, 3.3%, and 18% for the Roux-en-Y gastric bypass. Now, interestingly, majority of the gastric bypass complications were nausea and vomiting and strictures. Those 2 made up the majority of that 18% morbidity rate. Weight loss at 12 months was much more significant for the bypass. They dropped from 33 BMI to 23, whereas with the band patients, 33 to 29. Now, the primary endpoint here was remission rates, and there was a 36% remission rate for the band and 75% for Roux-en-Y gastric bypass. So that study is important because it is the first large study that has looked at using these operations to treat metabolic disease with patients with BMI lower than 35. So I think very, very important study. And so finally, probably the most important endpoint, of course, is long-term mortality. All of you are very familiar with these studies. There's 8 or 9 studies now that have looked at mortality effect of these procedures compared to control groups, and clearly, whether it's a gastric bypass or gastric band procedure, it appears that the long-term mortality is dramatically reduced. Before I close, I do want to thank my partners, Dr. Chan, Brett Hauer, Crow, Rogula, for participating in our work at Cleveland, and summarize by saying that there appears to be mounting strong evidence of a very significant anti-diabetic, anti-metabolic effect of these operations. The bypass procedures seem to be, although carrying a higher short-term risk, seem to deliver a greater impact in terms of remission than the banding type procedures. Thank you very much for your attention.